Welcome to the deep dive. Today, we're really getting into the weeds on mental health treatment. It's a huge topic.
It really is.
You've asked for a way to sort of get up to speed quickly but properly, understand the different views, the different options. So that's our goal today.
Yeah, and we've pulled together quite a mix of sources to help us do that. First off, there's a memoir, Unshrunk. It's one person's, very intense story about psychiatric care and, well, ultimately rejecting a purely medical view of her struggles.
Okay.
And then we've got some science looking at the biological side of behavior disorders, things like, believe it or not, brain surgery in some cases, and new directions for schizophrenia treatments.
Cautious optimism there, I should add.
Right, cautious optimism. And there's quite a bit more, too. We're looking at articles about people moving away from psychiatric meds, the real challenges in doing good research on psychedelics.
That's a tricky one. It is. Plus some potentially positive news like better access to clozapine, deep brain stimulation being explored for severe depression, and also this condition, depersonalization, derealization disorder.
Which can be really unsettling.
Absolutely. We'll also touch on combining, traditional therapy with alternative approaches. Look at some hard numbers from the big 2023 National Survey on Drug Use and Health.
That always gives us a sobering reality check.
It does. And then the basic pros and cons of mental health meds, a study specifically on side effects, and critically, how important it seems to be to taper off these medications slowly.
Yeah, very slowly. So our mission, if you like, for this deep dive is really to go beyond the simple narratives. We want to pull out the key insights from all this, look at the different treatment paths, acknowledge just how complicated it all is.
And give you a richer, maybe more nuanced picture of the whole landscape.
Exactly.
Okay, let's kick off with Unshrunk then. Laura Delano's story. So 14 years she spent in psychiatric treatment.
14 years. Yeah. Diagnosed with bipolar disorder, told it was this incurable brain disease. Medication was central.
But the core of her story really is this turning point. She rejects that purely medical explanation for how she felt, starts to see her suffering differently, maybe as part of life, and questions those diagnoses she'd been given.
Right. And this flags up a key theme: diagnostic uncertainty. It's not always clear-cut, even among clinicians. Delano felt the medical framing itself caused harm.
Harm? In what way?
Well, she talks about conceptual harm, like the medical language actually stopped her from understanding herself properly, and then interventional harm treatments that didn't work or had bad side effects.
Okay, I see. And you mentioned diagnostic uncertainty.
Yeah.
Even her own doctors weren't always on the same page.
Apparently not. While bipolar, I was the initial diagnosis. Others who treated her, and the person who wrote the foreword for her book, thought maybe borderline personality disorder or perhaps an unspecified mood disorder fit better. She even did a BPD program. So that disagreement itself tells you something about how subjective diagnosis can sometimes be. It's pattern recognition, not like testing for a virus.
So her pushing back against the diagnosis wasn't just about the specific symptoms, but the whole medical gaze, as the source puts it.
Exactly. It was rejecting being defined solely through that lens. And reading Anatomy of an Epidemic seems to have really crystallized this for her.
Robert Whitaker's book.
Yes. She started to believe the sister itself, the long-term medication, might actually be making things worse for her. That conviction led her to stop everything.
Which must have felt like a huge leap.
Immense. And the fact that she did function seemingly well outside that system after being told she couldn't became for her this powerful piece of evidence, her radical proof, she calls it.
But looking back, could things have gone differently within the system?
Well, a clinician reflecting on it suggests maybe. Perhaps if the explanations were clearer from the start. About what mental disorders are patterns of experience, not necessarily fixed brain diseases. About the real possibility of recovery. About meds being imperfect tools with side effects.
Maybe managing expectations better.
Perhaps. And it touches on this idea of agency. Did the system unintentionally take away her sense of control? Her recovery seemed tied to finding support elsewhere, like in AA, and rediscovering that personal agency.
It's a powerful story. But are there limitations to her perspective?
There have to be, right? It's one person's intense experience. It makes it hard, maybe impossible, for her to fully see the flip side that many people do get genuine life-saving help from psychiatric meds, and that some mental illnesses are incredibly severe and persistent.
She definitely lists negative effects from the meds, sexual side effects, feeling emotionally flat, physical health issues.
She does, though it's also mentioned she had emotional and behavioral difficulties before the medication started, so it's Well, it's complicated. Cause and effect are hard to untangle.
Yeah, it's never simple. Was there a point where a different approach was offered?
There's mention of one psychiatrist, Dr. Litwin, trying to explore wider social factors, things in her environment that might be contributing. But Delano at that point was so focused on the idea of a faulty brain that she couldn't really engage with that. A missed opportunity, perhaps.
And what about that insight on suffering?
That seems key. Her initial struggle was partly tied to this idea that life should be painless. Coming to accept that suffering is part of the human condition, something to navigate rather than just eliminate, was apparently a major shift for her.
A profound shift. Okay, so let's pivot from that very personal narrative to some other approaches and newer treatments. There's a striking case mentioned involving severe OCD.
Yeah, an attorney really debilitated by OCD. Years of therapy, meds, nothing worked effectively. Then he undergoes this very specific brain surgery, a targeted lesion.
Lesion, damaging a small part of the brain.
Exactly. And for him, it brought significant lasting relief. It sounds drastic, but it points towards, again, that cautious optimism for surgical interventions in very specific, severe, treatment-resistant cases.
So not a first-line treatment by any means.
Absolutely not. More like a last resort when everything else has failed. Now, thinking about schizophrenia, our understanding there is also evolving quite a bit.
Okay.
Traditional antipsychotics, the ones that primarily block dopamine, they can be effective, especially for the positive symptoms like hallucinations or delusions.
Right.
But they often come with significant side effects, and they don't do much for the negative symptoms, things like withdrawal, lack of motivation, or the cognitive problems.
But there's something new.
Yes. CAR-XT.
Mm-hmm.
It's a new antipsychotic that works differently, targeting another molecule, not just dopamine. This suggests schizophrenia is probably more complex than just a dopamine issue.
Which opens up new avenues for treatment, hopefully.
Hopefully. And alongside new drugs, there's also movement on existing ones. Clozapine, for instance.
That's known to be very effective for some people, right? But difficult to access.
Exactly. It's often considered the gold standard for treatment-resistant schizophrenia, but it carries a risk of a serious blood disorder called neutropenia. So regular blood tests were mandatory, which was a barrier.
Okay.
Now, the FDA has eased some of those requirements. Not removed the risk, of course, but made it somewhat easier to access this potentially life-changing medication for those who really need it. It's a risk-benefit calculation.
Always that trade-off. Shifting focus to depression. We see a trend mentioned, echoing Delano a bit, of people questioning long-term medication. There's an example of someone tapering off lithium.
Yeah, Daniel's story, it highlights that internal debate, do I still need this after all this time? It points to the importance of reevaluating treatment periodically.
And while some are tapering off, others with very severe depression are exploring really cutting-edge experimental options, like deep brain stimulation.
Right, DBS. That involves surgery to implant electrodes deep in the brain to try and regulate mood circuits. It's still experimental for depression, mainly for treatment-resistant cases.
And even less invasive tech is being tested, ultrasound.
Yes, an NHS trial using targeted ultrasound waves through the skull to modulate brain activity. No implants needed there. They're hoping it could help with depression, addiction, OCD, even epilepsy.
That sounds futuristic.
Yeah.
But raises questions too, surely.
Oh, absolutely. Big ethical questions around data privacy. Who owns the brain data, the potential for enhancement, not just treatment, even neurodiscrimination. Lots to consider as this tech develops.
Definitely. And what about psychedelics? We hear a lot about trials, but you mentioned challenges.
The main challenge is blinding. How do you do a proper placebo-controlled trial when the drug causes such a profound, obvious subjective experience, the trip?
Right, you can't really fool someone into thinking they've had psilocybin if they haven't.
Yeah, exactly. So researchers are getting creative, using different doses, sometimes giving the active drug to control groups, but under sedation to try and isolate the chemical effect from the psychological expectation. It's methodologically very tough.
Fascinating problems to solve. And finally in this section, depersonalization derealization disorder. Mrs. Miskin's story.
Yeah, her experience was triggered by untreated depression. It's this disturbing feeling of detachment from oneself or reality. It's a stark reminder that mental health issues can manifest in really unexpected ways, and one condition can trigger others.
Underscores the need for comprehensive assessment, doesn't it?
It really does. Things aren't always what they seem on the surface.
Okay, let's broaden the lens now to this idea of holistic mental wellness. What does that really mean in practice?
Well, fundamentally, it's about recognizing that mind, body, and spirit, however you define that, are all interconnected. You can't really treat one in isolation and expect optimal well-being.
So it's moving beyond just symptom management.
Precisely. It's looking at the whole person. And increasingly, we're seeing efforts to integrate traditional treatments like therapy and meds with other approaches, things like mindfulness, yoga, acupuncture, massage.
The idea being they work together synergistically.
That's the goal. And there's actually growing evidence to support it. Some studies show, for instance, that combining psychotherapy with mindfulness practices leads to better outcomes for depression than therapy alone, or using medication alongside yoga practice.
So it's not necessarily an either situation.
Not at all. The benefit of this holistic view is that it allows for really comprehensive care. It tries to address underlying factors, not just symptoms, and leads to much more personalized treatment plans tailored to what an individual actually needs and prefers.
The source mentions a treatment center, All Points North, APN, as an example.
Yeah, they seem to embody this by offering a really wide range of therapies under one roof. You've got the standard psychotherapy and medication management, but also newer things like TMS, ketamine therapy, alongside equine therapy, adventure programs. It reflects this idea that wellness is multifaceted.
It suggests a shift from just treating illness to actively fostering well-being.
I think that's a good way to put it. It's about addressing the whole person in their environment.
Now let's look at some numbers. The 2023 National Survey on Drug Use and Health, SAMHA's big survey. What are the headlines there?
Well, the headlines are pretty stark, as usual. High rates of current substance use across the board. Marijuana remains the most common illicit drug used.
And the connection between substance use and mental health.
It's very strong and very concerning. The survey shows large numbers of adolescents having major depressive episodes, and many adults dealing with any mental illness or serious mental illness. And crucially, there's a huge overlap.
Co-occurrence.
Exactly. High percentages of people struggling with both mental health issues and substance use disorders simultaneously. This makes treatment much more complex.
And are people getting the help they need?
Unfortunately, no. That's the other major finding. There are huge treatment gaps. A really significant portion of teenagers and adults who meet the criteria for substance use disorders and mental health conditions are not receiving any treatment for either.
That's deeply troubling, especially the co-occurrence part not being addressed.
It points to a massive public health challenge. We need much better integration of mental health and substance use services. People are falling through the cracks.
Okay, so with that context, let's zero in on mental health medication specifically. We know there are different types: antidepressants, antipsychotics, mood stabilizers, stimulants, anxiety meds.
Right, and they all work in slightly different ways on brain chemistry.
What are the main upsides? The pros?
Well, the biggest pro is that for many people, they work. They can significantly reduce symptoms, improve functioning, help people get their lives back on track. They're also relatively convenient, accessible for many, and sometimes more affordable than other intensive treatments.
But they're not a silver bullet. What are the downsides, the cons?
No, definitely not a silver bullet. They don't work for everyone. Sometimes you have to try several before finding one that helps, if at all. They can take weeks, even months to kick in. And then there are the side effects.
Which can be significant.
They can be. Things like weight gain, fatigue, sexual problems, dizziness, drowsiness. The list can be long and varies from person to person and drug to drug. It's definitely not a one-size-fits-all scenario.
So what's the takeaway?
The takeaway is that medication is one tool, an important one for many, but not the only one. It's crucial to have a really open conversation with your doctor about all the options, different types of talk therapy, lifestyle changes, maybe other interventions like TMS, to figure out the best path for you personally.
And that issue of side effects deserves a closer look. There was a study focusing on people with severe and persistent mental illness.
Yes, and it really highlighted the burden of side effects. High rates were reported. The most common types of bothersome side effects were related to sleep, mood, and changes in weight or appetite.
And the single most reported side effect?
Daytime sleepiness, which you can imagine really impacts daily functioning.
And did these side effects actually affect whether people took their medication?
Significantly. Over a quarter of the people in the study said they sometimes chose not to take their meds specifically because of the side effects. That's a major issue for treatment effectiveness.
Wow, over a quarter. That's huge. And did they talk to their doctors about this?
That's another worrying finding. People were actually more likely to tell family or friends about side effects than their doctors or other healthcare professionals.
That suggests a communication gap, doesn't it?
A big one. If doctors don't know about the side effects, they can't help manage them, maybe adjust the dose or try a different medication.
But despite these issues, did people still see benefits from the meds?
Yes, they did acknowledge the benefits too. Better symptom control, reduced suicidal thinking, avoiding hospital stays. So it's this constant balancing act for many people.
Which underlines the need for doctors to be really proactive, right?
Yeah.
Ask about side effects.
Absolutely. And to involve patients in shared decision-making, it can't be just a top-down prescription. The study also suggested pharmacists could play a bigger role here, checking in about side effects.
Interesting point. They also mentioned the pandemic potentially influencing mood-related side effect reporting.
Yeah, a slight caveat that the timing during COVID might have influenced how people perceived or reported mood changes. And of course, it's self-reported data using a specific questionnaire, so there are limitations. But the overall picture is pretty clear. Side effects are a major factor.
Okay, so if someone is taking medication, but maybe wants to stop or reduce it, this brings us to the crucial topic of tapering.
Yes, and this is incredibly important. Dr. Horowitz's personal account is really powerful here. He tried to taper off his antidepressant quite cautiously over 4 months.
Which sounds pretty careful.
It does. But he still experienced severe, persistent withdrawal symptoms. It really shook him and highlighted how little guidance there often is.
There isn't much solid research on how to taper safely.
Surprisingly little in the formal scientific literature. But what's interesting is the knowledge coming from patient communities, online support groups. People there report experiencing prolonged withdrawal even after standard tapers, and finding success only with very slow, gradual reductions, much slower than doctors typically recommend.
Why would slower be better? What's the thinking behind that?
It comes down to pharmacology, how the drugs interact with brain receptors. Simply reducing the dose by a fixed amount each time, say 10 milligram, doesn't necessarily lead to a smooth reduction in receptor occupancy, especially at lower doses.
Okay, explain that a bit more.
Think of it like this. The relationship between dose and receptor binding isn't linear. At lower doses, even a small dose reduction can cause a proportionally large drop in how many receptors are occupied by the drug. This sudden drop can shock the system, causing withdrawal.
Oh, I see. So a fixed percentage reduction might be better.
Potentially, or even smaller reductions spread out over longer periods. The idea is to reduce the drug's effect on the receptors more gradually and consistently, giving the brain more time to adapt. Horowitz calls it an evenly spread tapering plan, like turning down a dimmer switch very, very slowly.
And does this apply to antipsychotics too?
The principles are similar, yes, but because antipsychotics can have very persistent effects on dopamine receptors, the tapering process often needs to be even longer, potentially over years for some people.
It seems there might be a tension sometimes between a psychiatrist's focus on preventing relapse and a patient's desire to minimize medication harms or try stopping.
There can be. Some argue that the potential harms of the medication itself, including difficult withdrawal, need to be weighed more carefully against the risk of relapse. There's growing support for backing patients who want to try a very slow taper under supervision.
Is research catching up?
It's starting to. There's the RADAR trial specifically looking at slow antipsychotic tapering, and it's significant that major bodies like the Royal College of Psychiatrists in the UK have actually adopted the Horowitz-Taylor protocol for antidepressant tapering. That's a big step.
So the ultimate aim isn't necessarily to get everyone off medication.
No, not at all. It's about finding the lowest effective dose for each individual. And for some people, after a careful slow taper, that lowest effective dose might turn out to be 0. For others, it won't be. It's about personalization.
Okay, so drawing all these threads together from our deep dive, what are the main takeaways?
Well, I think the first thing is just how incredibly individual the mental health journey is. There's no single path. We've seen the complexities around diagnosis, the huge range of treatments, some helpful, some not, some with difficult side effects.
We've seen the value of looking at the whole person, that holistic view.
Definitely. And the profound impact of medication experiences, both good and bad. And critically, the need for real care and attention around managing medications, especially when thinking about reducing or stopping them. That slow taper message is vital.
It really underscores the complexity and the need for nuance. So here's a final thought for you, the listener, to mull over.
Given everything we've discussed, all the different experiences, the evolving science, the limitations of current approaches, how can we as individuals and as a healthcare system get better at collaborating?
Yeah, how do we truly personalize these mental health journeys? How do we move past maybe overly standardized ways of doing things and really make space for the unique, complex reality of each person's experience?
So I'm going to think about.